pioneers in the inception of CMEs in India. His boundless love towards Manipal and APGAP made him accept our invitation instantly amidst his busy schedule. We are deeply privileged to have you with us, sir. With a very warm welcome to you, sir. Awaiting to fine-tune our fundamentals. Over to you, sir.
Thank you. Thank you very much. Good evening to everybody. Thank you for this very nice and kind introduction. I'm really honored and humbled by that. Thank you very much again. The topic of my presentation is cardiovascular physiology. But before I start the presentation, I'd like to declare that I have no commercial or financial conflicts of interest to declare. If I promote a particular product or a drug in this talk, it is not because I was paid to do so, and I do it because I firmly believe that is the correct thing to do. Now, the topic is listed as cardiovascular physiology, and when Dr. Manjunath Prabhu called me and asked me if I would talk about it, I asked him, what essentially do you want me to address in this talk? And he said, I want you to talk about heart as a pump, address preload, contractility, afterload, systemic and pulmonary resistances. And he also said, you're free to modify if you want to. So what I'm going to do is, I am going to modify this lecture. I'm going to include other things other than the things that he asked me to address. Also, I'm going to do a slightly different approach. I'm not going to be presenting just theoretical concepts about preload, contractility, and afterload. There'll be some of that, but my focus would be to talk about the practical application of all these things from a practical viewpoint, so that you can actually apply it to your clinical practice, so that you can use it in everyday delivery of care to your patients. Okay, so at the end of this lecture, these are your learning objectives. You should be able to describe the mechanisms of regulation of arterial blood pressure. You should be able to define what preload, contractility, and afterload is and how they affect cardiac function. You should be able to describe the clinical indices of systolic and diastolic function. And you should also describe how regional blood flow is regulated. In most of the talks on cardiovascular physiology, people forget to talk about regional blood flow. And that's quite important because after all, what we want to do is to make sure that all the organs are well perfused when we take care of patients. So the heart is a pump. So what does it do? It pumps oxygenated blood to all the tissues. And we usually monitor pulse oximetry to make sure that the blood is well oxygenated. But then oxygenation of blood is really not a cardiac function. It's a pulmonary function. So what we do to monitor blood flow to the tissues is not to actually measure blood flow, but you measure blood pressure because you hope that the blood pressure is going to tell you something about the blood flow. And that's because flow is affected by pressure, and as shown in this particular hydraulic model. What you have on the top is, I'm trying to turn on the laser. Okay, what you have on the top here, I hope you can all see this green laser pointer here. You have a cylindrical tube in which the blood flow is taking place in this direction. This flow is proportional to the pressure difference between the proximal end of this tube and the distal end of the tube, shown here as P1 and P2. This is called the perfusion pressure because the proximal pressure is what pushes the blood. It must overcome the distal pressure to create any flow. So the difference between proximal and the distal pressures is called the perfusion pressure. And the flow is proportional to perfusion pressure and inversely proportional to resistance. This is the classic Ohm's law. It's used in electricity. It's also used in this hydraulic model of fluid flow. Now you can rearrange this equation to say perfusion pressure equals flow times resistance, or flow multiplied by resistance. And you can rearrange it further to say resistance equals perfusion pressure divided by flow. So let's talk first of all about resistance and address that issue first before we talk about pressure in detail. So what are the things that affect resistance? The things that affect resistance are three things mainly. One is the diameter of the vessel that has the greatest influence on resistance. Smaller the diameter, greater the resistance. The second thing that affects resistance is the viscosity of the fluid that's flowing through. And the third thing that affects resistance is the length of the tube itself. So using this formula, you can calculate the resistances, and then let's go and see how we can calculate systemic and pulmonary vascular resistance. So for systemic vascular resistance, the proximal pressure, the P1, is mean arterial pressure, and the systemic circulation ends in the right atrium. It goes through the artery, the venous capillaries, the venous side, and finally drains into the right atrium. So the distal pressure, P2, is the central venous pressure. Cardiac output, if you divide this perfusion pressure by cardiac output, you get systemic vascular resistance. If you apply only this part of the formula, your pressure is expressed in millimeters of mercury. Cardiac output is measured in liters per minute. So the systemic vascular resistance comes out as millimeters of mercury per liter per minute. And that's a very cumbersome unit to manipulate. So about 100 years ago, when everything was going metric, people said, why don't we express systemic vascular resistance in metric units? And so if you multiply this by 80, it converts the systemic vascular resistance units from millimeters mercury per liter per minute to the metric units, which are dyne second centimeter raised to the power of -5. Okay, again, I want to emphasize the units are dyne second centimeter raised to the power of -5. It is not dyne per second, it's dyne second. Okay, so normal systemic vascular resistance is between 800 and 1200 dyne second centimeter raised to the power of -5. In the pulmonary circulation, the proximal pressure P1 is mean pulmonary artery pressure, and the pulmonary circulation ends in the left atrium. So the P2, or the distal pressure, is left atrial pressure. The difference between the two will give you the perfusion pressure for the pulmonary circulation, divided by cardiac output, multiplied by this conversion factor, will give you normal pulmonary vascular resistance of 150 to 200 dyne second centimeter raised to the power of -5. It turns out that in both systemic and pulmonary hypertension, the resistance has to be increased. If the resistance is not increased, it is not hypertension it is not labeled as hypertension. It is high blood pressure, it could be due to increased cardiac output or increased flow, but it's not pulmonary hypertension or systemic hypertension. The diagnostic feature of any hypertensive state is that the resistances in those particular vascular beds have to be increased. Now let's go back to the previous formula where we talked about perfusion pressure equals flow multiplied by resistance. And we measure pressure most of the time. And if pressure changes, the only way you can bring it back to normal is to manipulate either flow or resistance. And that is how the body itself regulates blood pressure or perfusion pressure. And that is shown on the next slide. There are two mechanisms for regulation of blood pressure in the body. The first mechanism is called the baroreceptor mechanism, and that is quite quick and rapid. It sets in within a matter of a minute, and the body responds to changes in blood pressure through this mechanism within a very short time. So let's say you have a decrease in blood pressure. What happens is there are receptors, high pressure baroreceptors, located in the aortic arch right here. And there are also high pressure baroreceptors located in the carotid sinus and the carotid artery at the bifurcation of the common carotid artery into internal carotid artery and external carotid artery. When the baroreceptors detect the low pressure, they relay that information from the aortic arch. It is relayed through vagus nerve to the vasomotor center. From the carotid sinus baroreceptors, it is relayed through glossopharyngeal nerve to the vasomotor center. And when the vasomotor center receives information that the blood pressure is decreased, it activates the sympathetic nervous system, which first of all goes through sympathetic nerves and stimulates the heart, increases the cardiac heart rate and contractility, the force of contraction, so that both stroke volume and the heart rate go up and the cardiac output goes up. So the flow is increased in order to bring the blood pressure back to normal according to the formula that we saw before. In addition, the sympathetic nerves also cause vasoconstriction in the systemic blood vessels, thus raising resistance. So the baroreceptor mechanism increases blood flow and resistance to restore blood pressure back to normal. Now, the opposite happens when there is an increase in blood pressure. When the baroreceptors detect an increase in blood pressure, the information is relayed to vasomotor center. This time, instead of activating the sympathetic nervous system, it activates the parasympathetic nervous system through the vagus, which slows down the heart rate and the contractility. And it also causes vasodilation and restores blood pressure or normalizes blood pressure back to its usual levels. This mechanism, as I said before, takes place very soon, very rapidly with changes in blood pressure. And the important thing for us to remember is that when you give anesthesia, most anesthetic drugs will depress baroreceptor mechanism to some extent or the other. Some drugs like barbiturates depress it more than other drugs such as etomidate and ketamine. So there is variable depression of baroreceptor mechanism by anesthetic drugs that we use. The second mechanism of regulation of blood pressure is through the renin-angiotensin-aldosterone system. And what happens here is a decrease in pressure makes the kidney release renin. Now, there are also other things that stimulate the kidney to release renin, such as sympathetic activity and decreased sodium delivery, but those are not the things that we're talking about. We're talking about only blood pressure regulation. So any decrease in blood pressure will make the kidney release renin. It's a common misunderstanding that the renin is released by decreased blood flow to the kidney. In other words, kidney ischemia will cause renin release. That is not true. It's actually the decrease in pressure in the afferent arteriole of the glomerulus that causes renin release from the juxtaglomerular apparatus. This renin activates angiotensinogen, which is a precursor coming from the liver, and converts it to angiotensin 1, which is not the active form. Angiotensin 1 is converted to angiotensin 2 in the lung by angiotensin converting enzyme. Angiotensin 2 is one of the most powerful endogenous vasoconstrictors. In some studies, it's shown to be more powerful than norepinephrine or noradrenaline. So this angiotensin 2 will immediately work on the blood vessels, causes vasoconstriction, and raises systemic vascular resistance, and so will restore blood pressure partially. Angiotensin 2 also acts on the adrenal cortex and releases aldosterone. It also acts on the brain and releases antidiuretic hormone. These two hormones act on the kidney. The aldosterone acts on the loop of Henle to facilitate sodium reabsorption. The antidiuretic hormone acts on the collecting tubules to facilitate water reabsorption. So sodium reabsorption, water reabsorption will increase the blood volume, will increase cardiac output, and go on to increase blood pressure. So in this mechanism, again, there's an increase in resistance, an increase in flow to increase arterial pressure back to normal. This mechanism of blood pressure regulation is a little bit slow to set in. It takes some time for renin to release. It takes some time for it to activate angiotensinogen. It takes some time for it to be activated to angiotensin II. All of this will take about anywhere from a few minutes to maybe as long as 10 minutes for the peak effect to take place. So we've talked about the pressure. Now let's talk about the flow. And flow is usually, the cardiac output is referred to as the flow in the Ohm's law, Ohm's equation that I showed you before. Cardiac output is, as I mentioned earlier, is expressed in units of liters per minute. So if you take the heart rate and the stroke volume, that is the volume ejected during each cardiac cycle, during each contraction, is constant. If you multiply stroke volume with each heartbeat, multiplied by the heart rate, you get cardiac output. And that's very simple. So one of the ways of increasing cardiac output is to increase heart rate. And we see this quite often in practice. If you give some parasympatholytic agents such as atropine or glycopyrrolate, the heart rate goes up and the blood pressure will also go up because the cardiac output has gone up a little bit. This increase in cardiac output with changes in heart rate happens only up to a maximum heart rate of about 160 or so. It may be up to 180 sometimes. Beyond that, when the heart rate becomes that rapid, there is not enough diastolic time for the heart to refill. So the heart rate does further increases in heart rate will not increase cardiac output. Maximum range is somewhere within 160 to 180. That's about the peak heart rate that most athletes can achieve when they're exercising maximally. Stroke volume can, of course, be affected by the other three things listed here: the preload, contractility, and afterload. And we'll talk about each of these things separately. And first, I'll talk about preload. Now, what is preload? Preload was a concept that first started with a person by the name of Starling. He was a professor of physiology and the cardiovascular system. And he enunciated this law 150 years ago, sometime in 1860 or 1870. And he came upon this intuition by doing some experiments in dogs where he raised the central venous pressure and saw that it increased cardiac output. And from that, he was able to deduce the Starling's law of the heart, which says the force of contraction is proportional to the initial length of muscle fiber. So again, the Starling's law of the heart says force of contraction is proportional to the initial length of muscle fiber. So what is meant by that? So here is a schematic of an individual muscle fiber that is connected to a force transducer. So when you stimulate this muscle by electrical stimulation, we have done all these experiments in physiology, the muscle contracts, and the force of contraction can be measured by this force transducer. So if you now take this muscle and add a load and make it stretch, and then after you stretch it, if you make it contract, it is going to contract with a greater force of contraction. It is going to lift the preload, and the force of contraction is going to be much greater than you see in an unloaded muscle. This load on the muscle that is put there before it contracts is called the preload. It is before the contraction. That's why it's called preload. And it makes sense now because we know that the actin and myosin filaments riding on top of each other is what makes the contraction happen. And if you stretch the muscle and separate the actin and myosin a little bit more, you're going to create more binding sites for actin and myosin to form bridging, cross bridging, and so the contraction is going to be more forceful. Now, this is going to happen only within certain physiological limit, because if you stretch it too much and the actin and myosin filaments are no longer riding on top of each other, then they cannot form cross bridges and it's no longer physiologic preparation. It is amazing how Starling came upon this intuition, because he did this even before he knew things such as actin and myosin. At the time that he came up with this law, there was no concept of actin and myosin filaments because they had not invented electron microscopy, nobody knew that there was the microstructure of muscle cell had actin and myosin filaments riding on top of each other, and that's what causes contraction and shortening of the fiber. So it's really amazing that he came upon this concept. And what happens in clinical practice is, if you look at it in the intact heart, the preload or the initial length of the muscle fiber is determined by ventricular end diastolic volume before the actual systole occurs. So the ventricle fills, the filling of the ventricle will stretch the muscle fiber during diastole, and at the beginning of systole, the muscle fiber will be maximally stretched, and then you can go ahead and have a contraction. So if you know the ventricular end diastolic volume, you have a measure of preload. But ventricular volumes are difficult to measure. This is a point that I'll come back to again and again, that ventricular volumes, we talk about that as preload, but it's really difficult to measure in clinical practice. You can do it in experimental animal preparation in the dog lab. You can do it in some cases in the human, if you want to do studies, but to do routine measurement of ventricular volume is very difficult. So what we do is we use ventricular end diastolic pressure as a surrogate for ventricular end diastolic volume. And that makes sense because if you increase the pressure inside the ventricle, it is going to stretch the fibers as well. The increased pressure will increase the volume by stretching the muscle fibers. So if you use end diastolic pressure as your preload, and that is shown on the horizontal axis here, and on the vertical axis is some measure of the force of contraction, that is cardiac output. You can also use stroke volume if you want to hear. So stroke volume or cardiac output will be a measure of the force of contraction generated by the ventricle. So let's start here in a person with a low end diastolic pressure, and the cardiac output is at this point. If you now infuse some fluid or blood and raise the end diastolic pressure from this point to this point, the cardiac output is going to go up to this. If you increase it further, it's going to go up even more. If you increase it maximally, it's going to achieve some point. Beyond the physiologic limit, it is no longer applicable because you're no longer a physiologic preparation or physiologic model. Now the question is, there is an increase in the force of contraction from this point to this point that results in increased stroke volume or cardiac output. Is increased force of contraction same as contractility? By definition, it is not. A lot of people will say the increase in preload causes the contractility to go up. That is a mistake. By tradition, by definition, the increase in force of contraction due to increase in preload is called the Starling effect. Some people call it the Frank-Starling effect because Frank was a person who came later on and refined this model. So it's called the Frank-Starling effect or the Starling effect. The increased force of contraction is not called increase in contractility. Contractility is shown in the next, okay. The concept of contractility is illustrated in this slide. The previous slide that you saw was this one, where you saw the Frank-Starling curve in a normal person. And the next slide shows what happens when you increase contractility and decrease contractility. So take the same person right here at a low end diastolic pressure and low cardiac output. Without increasing preload, if you give something that increases contractility, such as adrenaline, the force of contraction goes up. There's an increased cardiac output at the same preload. The preload is not changed. In this person, if you now give additional fluid and raise the pressure, the preload from this point to this point, the cardiac output goes up even higher at a bigger rate, at a faster rate. The slope of this line is much steeper than the slope of this line. And that happens throughout changes in preload for this person with increased contractility or increased inotropism, as we call it. Similarly, if you take the same person and give something that will decrease contractility, such as beta blockers, you will reduce the force of contraction and the cardiac output will come down even though the preload is not changed. And that happens throughout the curve. As you increase the preload, the slope of this change is much shallower than this one, much shallower than the one with increased contractility. So this defines what contractility is all about. Contractility change, the force of contraction that changes without a change in preload is called contractility. The force of contraction that changes with preload is stalling effect. Now let's talk about afterload. So in this slide, you see the previous preparation that I showed you for preload. Here's an unloaded muscle. Here's a muscle that has been loaded with something and stretch the muscle before it contracts. Now, after you add the preload, if you put a support at the bottom, and then you add additional weight to this, the muscle is not going to get stretched because this support is going to prevent any further stretching of this muscle fiber. The muscle will see this load only when it is contracting and when it lifts the preload off this support system at the bottom. If the load is very heavy, the muscle may not contract at all, but it will be reflected in the muscle as an increase in tension. The tension in the muscle will go up. It may not shorten. It may not have any contraction because this tension is a reflection of the load against which the muscle is contracting. So the afterload is also the load against which the muscle contracts, and the tension in the muscle is reflected by the afterload. And some people define afterload as a tension developed at peak contraction. So a surrogate measure of afterload is a tension that is developed in the muscle at peak contraction. Things that affect afterload, there are some intracardiac factors and some extracardiac factors. The main thing that influences afterload in intracardiac, within the heart, is defined by Laplace law. And the extracardiac factors are impedance to ejection due to arterial stiffness, vascular resistance, and so on and so forth. So these are the main things. Let's first look at the intracardiac factors and define what Laplace law is. Laplace law states simply that if you take a distensible, say, object, balloon, closed distensible object, the tension on the wall of the vessel is proportional to the pressure inside it and the radius of the curvature of this vessel. Again, tension is a difficult concept to describe because the units of tension is dyne per centimeter. Dyne is a unit of force. It doesn't make any sense when you say the tension is so many dynes per centimeter. But intuitively, you know what tension is. If the balloon is not fully inflated, let's say you take a balloon, it's not fully inflated, and you poke on it with your finger, it doesn't feel very tense. Your finger sinks into the balloon, and it feels kind of loose. So the tension is low. If you inflate the balloon fully, and it's stretched, and you poke on the wall of the balloon, it feels tense, it feels tight, and that's increased tension. So the tension is determined by pressure and radius, and you can rearrange the equation to say pressure inside the vessel is proportional to the tension on the wall divided by the radius. So what this tells you is that the pressure is proportional to tension and inversely proportional to radius. So if the ventricle is dilated or enlarged, as happens in cardiac failure, for it to develop the same amount of pressure, the tension on the wall has to increase. So a dilated, failing heart has to develop more tension in order to develop pressure to open the aortic valve and provide ejection. So the afterload significantly goes up in patients with the dilated ventricle. So this is how Laplace law affects on the heart to increase the afterload. The extracardiac factors, as I mentioned before, are the arterial stiffness. If the artery is stiff, it doesn't expand with each ejection, then it doesn't accommodate the increased volume. and increased vascular resistance will both impede ejection, and those also increase the afterload. It increases the tension on the muscle, on the ventricular muscle. To overcome this impedance, the ventricle must develop increased tension. That is, the afterload goes up in this case itself. Remember, we defined out one of the definitions of afterload is an increase in wall tension, increase in tension in the ventricular myocardium. So the effect of afterload on cardiac output is shown on this slide. Here is a normal patient, and on the horizontal axis is afterload. This is normal afterload, and this is afterload that is almost the double of normal, twice normal. And if you take this person, for this afterload, a normal person will have a certain amount of cardiac output. If you increase the afterload acutely by, say, partially clamping the vessel, clamping the aorta partially, not completely, if you acutely raise the afterload, what happens is the cardiac output initially comes down, but within a matter of seconds, there's an increase in contractility as a result of an increase in afterload, and the cardiac output is restored. And this is called the Andrup effect. Andrup is a person who first described this, and it says when the afterload goes up acutely in somebody who's normal, the cardiac contractility will increase. It is unaffected. The contractility is not affected by the afterload. It increases to restore cardiac output back to normal by increasing the force of contraction. If you increase the afterload further, again, Andrup effect sets in a normal patient, and the cardiac output is restored. This goes on till the resistance is acutely raised to beyond twice normal limits. If it goes beyond twice normal, then the cardiac output starts to drop as you further increases in resistance, further increases in afterload. If you take a person who is in heart failure, what happens is, let's assume a person with a normal resistance and heart failure will have a decreased cardiac output. That is the definition of heart failure. The heart is not pumping adequately. The cardiac output is decreased. In this person, if you increase resistance acutely from this point to this point, the cardiac output is going to decrease right away. Further increases in resistance will cause further decreases in cardiac output. This forms the basis of treatment of congestive heart failure. In patients in congestive heart failure, the mainstay of treatment these days is to give vasodilators that will decrease systemic vascular resistance and decrease afterload. When I was going to medical college almost 50 years ago, the main treatment of congestive heart failure was to give them diuretics and digoxin. Now, digoxin made patients feel better right away, but digoxin has been shown in large studies not to provide any survival benefit. It doesn't increase prolonged survival in patients with congestive heart failure. So digoxin has almost been abandoned in Western countries. I think it's the same practice in India as well, in developing countries as well. So the mainstay of treatment is to give vasodilators that decrease systemic vascular resistance. And since systemic vascular resistance is one of the things that increases afterload, any decrease in systemic vascular resistance will decrease afterload from, say, this point to this point, and thus increasing cardiac output back towards normal or towards resting conditions. Now, the first vasodilator that was tried in large clinical trial was angiotensin converting enzyme inhibitor called enalapril, which is no longer used. The more commonly, we now use lisinopril as the most common one. We can also use angiotensin receptor blockers such as losartan to achieve the same effect. So the mainstay of treatment in congestive heart failure is to reduce the afterload so the heart can pump against less resistance and improve cardiac output. So now we can define, having defined preload and afterload, we can further refine contractility, definition of contractility as the property of cardiac muscle where the force of contraction is independent of loading conditions. Loading conditions such as preload and afterload does not affect contractility, and the contractility is affected mainly through beta receptors. How do you measure contractility in clinical situations? Well, we can go back to the original Starling curves that I showed you before. You can take somebody and measure the preload, the end diastolic pressure, measure cardiac output. These things can be done very easily in clinical practice. We do it quite often. The way to do this is to insert a pulmonary artery catheter, and that will measure the left ventricular end diastolic pressure indirectly. You can also measure cardiac output using a pulmonary artery catheter. So with cardiac output and left ventricular end diastolic pressure, you can plot your Starling curves. And you can define a slope for each of these things and say this particular slope is normal, this is increased, and this is decreased, and so on and so forth. But this takes time. We used to do this routinely in the ICU. We used to even do it sometimes in the operating room in cardiac patients undergoing cardiac surgery. But it's cumbersome because you have to, first of all, measure end diastolic pressure and do cardiac output, and then infuse fluids in this patient, and then measure cardiac output at different end diastolic pressure. All of this takes time. It takes 15-20 minutes to construct one Starling curve. So it's not practically useful. So to measure, to use Starling curves and define a particular slope for the Starling curve and say this is within normal limits, this increased slope is increased contractility, and so on is not very practical. What the textbooks will tell you is that you can measure cardiac contractility by left ventricular pressure volume loops. Now, I'll tell you what pressure volume loops are. These are pressure volume loops in one single person or one single subject. Each of these outline that I'm tracing with my laser pointer is one cardiac cycle. So these are cardiac pressure volume loops at increasing preload. Left ventricular volume is shown on the horizontal axis. So these, as you increase the preload, the cardiac pressure volume loop becomes bigger. Okay, so this is the same person. So what is shown on the horizontal axis, left ventricular volume. What is shown on the vertical axis, left ventricular pressure. And this is the diastole during which ventricle is filling. The pressure in the ventricle is very low during diastole. At the end of diastole, the left ventricular volume comes up quite a bit, but the left ventricular pressure is still low. Now, systole sets in. The pressure in the ventricle goes up rapidly, but there is no change in volume because this is the period of isovolemic contraction. At this point, the pressure in the ventricle exceeds the pressure in the aorta. The aortic valve opens and ejection takes place, and the ventricular volume rapidly comes down. The ventricular volume comes down, and the pressure still goes up because the ventricle is still contracting. It reaches peak pressure, and the volume is now markedly different, much lower. At the end of diastole, the pressure is increased maximally, the volume is minimal. And at the start of diastole, you have this little inflection point that is before diastole begins. And at the beginning, during diastole, the pressure rapidly drops and the volume doesn't change. And this is the period of isovolemic relaxation. And then this is the start of diastole. Again, the ventricle fills, and this becomes the left ventricular end diastolic pressure, left ventricular end diastolic volume. So as you increase the preload, you have increased ejection, increased force of contraction, and bigger pressure volume loops. This is a patient in whom the preload has been changed, and these different pressure volume loops have been generated. Now, it turns out this particular red line, it says ESPVR. It stands for end systolic pressure volume relationship. And the slope of this line that joins the end systolic point at which the pressure is maximal and the volume is minimal. And if you join all these points, you get the end systolic pressure volume relationship. And the slope of this line is supposed to indicate a measure of contractility. Okay, so this is shown on the next slide. And here is again a patient or a subject with normal contractility. Again, this is the diastolic duration. This is the end diastolic volume, isovolumic contraction, ejection, end systole, isovolumic relaxation, beginning of diastole, and so on. And this is a patient, the one in red is a cardiac cycle in somebody with increased contractility or increased inotropy. These two dotted lines, this red dotted line here and this black dotted line here, are the end systolic pressure volume relationships. And the slope of this line is supposed to indicate measure of contractility. This slope is much shallow. This is steeper. The pressure rise is much higher here for a volume change. And so this is supposed to be increased contractility. I told you already that volumes are very difficult to measure. 95% of the studies that are published in the literature showing pressure volume loops are done in animals. It is very difficult to measure volume during a cardiac cycle in human beings. You can do it. It can be done in special studies where you do human subjects who volunteer for such studies. You have to put a catheter in the left ventricle. You cannot put it through the septum. You have to put it into the artery, float it into the aorta against the flow, go retrograde through the aortic valve into the ventricle, and leave the catheter there. It's called a conductance pressure tip transducer catheter. It measures velocity of the, measures the volume of the ventricle by a principle called the conductance principle. It measures the pressure as well, and it can draw a pressure volume loop during one single cardiac cycle. But it's not something that is easy to do in the clinical situation. You can do it in human beings for experimental purposes, but not for routine clinical practice. Besides, each conductance catheter costs something like $500, and it's very expensive to do even in Western countries, and nobody does it clinically. You cannot measure pressure volume loops by transesophageal echocardiography. You can measure volumes, but not pressure. You can get an estimated pressure difference across the valve in echocardiography, but you cannot actually construct pressure volume loops. You can assume a pressure with transesophageal echocardiography and measure and construct a pressure volume loop, but it's not actual pressure volume loop. You need a conductance catheter. So what can you use as a measure of contractility or a measure of contractile function of the heart or the systolic function of the heart? After all, systole is when the ventricle contracts, and the force of contraction is proportional to preload, as we saw. Its force of contraction is proportional to contractility and is inversely proportional to afterload. So you can combine all these things, and the thing that measures the systolic function of the heart during clinical purposes is the ejection fraction. What we use is the ejection fraction. Ejection fraction is the proportion of end diastolic volume that is ejected with each systole, and is given by this formula. You take the end diastolic volume, you subtract it from the end systolic volume, that is the stroke volume, and you divide the stroke volume by end diastolic volume, and you get ejection fraction. And the normal ejection fraction is between 55 and 65%. What this means is that a normal ventricle will eject 55 to 65% of its end diastolic volume during systole. And this ejection fraction reflects changes in force of contraction due to preload, contractility, and afterload. If the preload goes up, the ejection fraction will go up. If the contractility goes up, the ejection fraction will go up. If the afterload increases, the ejection fraction will go down, unless, especially in a patient in heart failure, because in normal patients, an increase in resistance or afterload is compensated by the ANDREP effect, as I mentioned earlier. So ejection fraction is a very useful measure of systolic function of the heart that can be used for clinical purposes. Do we use ejection fraction clinically? Of course we use it. We may not use it in all patients, but in certain specialized patients, such as patients undergoing cardiac surgery, we put in a transesophageal echo probe. And by looking at left ventricle in short axis or even in long axis, you can visually estimate ejection fraction. And an experienced sonographer or echocardiographer will look at the ventricle and how it contracts and how much is empty during a systole, will be able to guess what the ejection fraction is. And if you're experienced enough, it is pretty close to actual measurement of ejection fraction. Or if you don't want to actually guess the ejection fraction by looking at the contraction, you can actually measure it. All you have to do is take a clip, freeze a clip of a cardiac cycle in your echocardiography machine, scroll to the maximum volume of the ventricle, which is diastole. You can trace the outline of the cavity, and from that you can measure the volume using a formula. And you can scroll down to the systolic portion where the ventricular cavity is really small, measure the volume by tracing the ventricular cavity. And from that, you can measure the end diastolic volume and systolic volume and get the ejection fraction. Tracing the outline of the ventricle in diastole and systole is not very difficult to do. An experienced echocardiographer or a sonographer can do it within 1 minute. So you can get ejection fraction measurements within a minute in clinical practice while you're actually doing cardiac surgery or immediately after coming off bypass and so on and so forth. In some places where I practice, we use transesophageal echocardiography not only in cardiac surgery, but also in cardiac patients who are undergoing non-cardiac surgery who have severe cardiac disease. Patients with ejection fraction, severe congestive heart failure, undergoing, say, Nissen fundoplication or colectomy for cancer. We'll put an echo probe, a transesophageal echo probe, and monitor the cardiac function intraoperatively as well. So it can be used in very sick cardiac patients undergoing non-cardiac surgery. It's routinely used in patients undergoing cardiac surgery all the time. So we've talked about systolic function or contractile function of the heart. What about diastolic function? Well, diastole is a big part of cardiac cycle. In fact, diastole occupies almost 60% of a cardiac cycle. Systole occupies only about 40%. So we need to talk about diastolic function as well. And we're going to talk about that after we take a break at this point. So we'll take a break. You can go and do something else, come back in about 10 minutes, and we'll talk about diastolic function